How are you? Okay, how are you? Good.
Morning, everybody. Welcome to Grand Rounds. It's a pleasure today to introduce Dr. Grace Lee, one of 5 physiatrists that serves PHC. And Dr. Lee is going to speak to us on stroke, brain injury, and physiatry.
Thank you. So nice to meet you. I am a physiatrist that I work at a few different hospitals, including here in the Lower Mainland. I work at Sunny Hill, GS Strong, and Holy Family in Providence, as well as I visit at Prince George and Whitehorse, so I have some idea of what rehab is like in those places as well. So today, I wanted to talk about what the rehab infrastructure is like for patients in BC, present a case, and then talk to you guys about some definitions and relevant numbers and the evidence that we have for rehab. And so this is more so, this part of the talk is because I know a lot of people probably have very limited exposure to what rehab is, where rehab is served, and what the different kinds of rehab are that are available for patients. So this is more to explain what is out there, this section. So where is there rehab available? And usually one of our first questions we ask is, can you be serviced by your home health authority, or do you have some special needs that that your home health authority can't service and that you need to be sent to a tertiary facility? So this is a map of the health authorities in BC. And there are intensive rehab centers at each of those health authorities, except for the Yukon. So usually patients from the Yukon we treat as living in Vancouver in some sense in terms of where they will receive their rehab, because there's no intensive rehab in Yukon. There's some limited therapy available through the hospital though. Otherwise, each of the health authorities all have their own more intensive rehab centers. And then beyond that, if you don't qualify for intensive rehab, there are other places that you may be appropriate for or be able to go to. These places are usually less intense and may or may not call themselves as rehab. They may be reactivation units or some lower level of therapy available or limited therapy depending on where you go. So common ones you might hear of are UBC, private rehab places that are available. There is a center in Alberta where very severe and slow patients may be appropriate for, and they will fund on a case-by-case basis, and then convalescent care. And then if you're still not appropriate for any of those other places, then you might be considered for some type of alternate living situation like a ECU, extended care, or long-term care, or a group home, or some kind of supported living environment. If you are living in Vancouver or the Vancouver area, one of the how we separate people for rehab is based on age in large part. So if you are young, there's not really any pediatric rehab outside of Sunny Hill. So if you have some need for inpatient rehab, probably you will be going to Sunny Hill no matter where you live in the province. And then teenagers to age 65 would go to GF Strong. And you have to be able to sleep over by yourself and not need your parent there in terms of the young age group. And then people 55 and above would typically go to Holy Family with some caveats. And so there are certain things that each center can offer or provide, and each center is a little bit different what they can provide or manage. So Sunny Hill and GF Strong can both manage ventilated patients, but these are usually patients that we anticipate will need ventilation in the long term, and working towards them learning how to manage and their family learning how to manage, but not for patients who need ventilation in the short term because of some temporary respiratory issue, and you anticipate that they won't need ventilation in the long term. We don't usually take people who have a brief need for tracheostomy or something like that. Other kind of key differences, Holy Family takes patients who are on peritoneal dialysis, and unique in that sense, and can manage that. I'll say Holy Family, there's two areas. One is the extended care area, where they also have peritoneal dialysis patients, but that is completely separate from the rehab area, which is on a different level, but similarly can manage peritoneal dialysis. And then usually we don't see people who need one-to-one or involuntarily admitted. None of these places are locked, so we can't, there's no wander guard or something like that. So if they need that, then they're not able to be seen at these rehab places. There is one locked ABI unit in Fraser. And so these are some medical things that the nurses can handle at these sites. And let me know if there's questions. So we, I guess, conventionally think of if you've had a stroke, you come to somewhere like St. Paul's or acute care hospital, and then hopefully you will go to a rehab center and then go home. But not everyone really follows this pathway or needs to follow this pathway. So it's possible that after your acute care stay, you're not appropriate or able to go to a rehab center, so you may go somewhere else, and then from that, after that, it's possible to then go to a rehab center, and then hopefully go home, or from long-term care or reactivation area like UBC, be able to go home. And then sometimes it happens that patients from the rehab center don't make it home for a variety of reasons. We try to minimize that number, and so they might need to go to long-term care or a group home or some kind of supported living environment. And so it happens often. I think people are always worried that if we don't take people into rehab, then that means, and they end up going to long-term care, that they'll never go to rehab, and that's certainly not the case. I was just talking to our admissions person at GF Strong, how she was telling me someone was just admitted to GF Strong from Pearson. who needs some ventilatory support. So it is possible and it doesn't have to be this kind of conventionally thought route of straight through. So I wanted to tell you guys, or talk to you about two girls that I saw this past summer who were very similar in some sense. They're both 12 years old, perfectly healthy before their injuries. And person on your left, Annie, she was involved in a ATV rollover, so her and her cousin were in a side-by-side ATV. Her cousin was ejected from the ATV, but the ATV happened to land on this patient's chest. And so she was initially conscious. She was able to hand over her phone to her cousin, tell them to call for help. And then she, due to the weight of the ATV, kind of became progressively blue and became unconscious after that. So she needed CPR. She wasn't wearing a helmet at the time. And then when EHS saw her, she had a fixed right pupil. Similarly, Chloe also had a fall off of a horse, immediately unconscious, decerebrate, and with low score, both immediately needing some ventilation support. And so when they went to the hospital, both didn't have any obvious bony fracture, no other orthopedic or other obvious injuries. Their main injury was to their head. You can see this is the MRI for Annie. I think it was done like 2 or 3 days after, showing a lot of edema and swelling and some changes of diffuse axonal injury, but no bleeds at all. Versus Chloe, she had multiple innumerable hemorrhagic changes. This was the worst one, but there were, I think, over 20, a lot of bleeds throughout. And this lower down, also many bleeds for Chloe, but not really for Annie. And so both were in bad shape. The person on your left, she needed constant ventilatory support, so a decision was made to withdraw ventilation after about a week due to poor prognosis. And as they took her off, she started to breathe on her own, and so there was some hope that she would improve. Chloe very similarly needed ventilatory support for about a week or so, but she was able to wean off. She was cooled acutely. And so, and both arrived at Sunny Hill about 1 month after their injury. They're both vegetative, which means that they're not in a coma, so they're not being artificially ventilated. They have some day-night awareness, that their eyes open during the daytime, closed during night, but not able to track, not able to reply or respond consistently, no pain stimuli, no obvious ability to interact with the environment. And another caveat is that Sunny Hill takes patients in this lower, like disorders of consciousness and lower level of consciousness state, versus GF Strong and Holy Family wouldn't take patients in with this low level of functioning due to a variety of reasons. And so it was very interesting because both girls came in at around the same time. And person on your left, she stayed for about 5 months, and she made almost no recovery. She was persistently vegetative, no obvious response to stimuli. She was very dystonic, and no purposeful movements, no eye tracking, needed PEG tube feeds, Foley, and was very similar to when she first came in. Versus Chloe, who is still at Sunny Hill, is about 5 months now, and she's made amazing recovery. She's able to get up off of the floor. She's very ataxic, but she is quite strong. She was initially quite hemiplegic, but that has recovered a lot. So she's able to talk now, able to follow two-stage commands, and able to form short sentences, and able to eat. She's still getting peg tube fed, but able to eat somewhat, and is making a lot of improvements. So whereas they seem very similar in the beginning, there were some prognostic factors that we look at as physiatrists or rehab doctors, and could we have better predicted which person would have done better, which person would have done not so well, to kind of maximize the use of them being in rehab. Because for patients to be in rehab, it is quite a commitment for the whole family. In the children's world, someone needs to stay with them, and so often it's very challenging. People are from out of town, and you'll hear a little bit later of if the family necessarily values them being in rehab, because it is tough when you see other people improving around you and you're not improving. It can be very emotionally challenging, and so this prolonged stay for this girl was perhaps not the best use of everyone's time, versus and resource management, using that bed, taking that bed from someone else who may be able to better use it. As you guys might be aware, there's often a long wait list to get into rehab because the beds are a limited number, and we can't necessarily have difficulty discharging people due to a variety of issues. So was that bed kind of well utilized? So some numbers and definitions. So this talk is specifically focusing on people with severe injuries, which is not the largest group of patients after stroke, but a very narrow group of patients after stroke. So this is a chart of what happens to all comers after stroke from an international study. So you'll see this is based on the modified Rankin scale, which is a validated scale for outcome after stroke based on mobility. It goes from 0 to 6. 0, you're fully recovered, no symptoms at all, very minor disability, able to do everything, but you feel maybe a little bit of numbness or dizziness, but you're still able to do whatever you were doing before. Slight disability, not able to do exactly everything you were doing, but you're still very independent. Moderate disability, but still able to walk on your own. Moderate to severe, where you can't walk alone or manage your ADLs independently. Severe disability, or death. So what this talk is talking about is this group of patients. Obviously, these people down here, maybe about 40%, don't really need rehab. This group as well, for the most part, should be assessed, but doesn't necessarily need rehab because they will improve very well. The average group of person that we're trying to target for rehab is this moderate group. There's kind of a gradation between here, but maybe this 30% of people who have significant enough disabilities but are still have a good trajectory for improvement, and we imagine that they will be able to do things for the most part by themselves, or at least those important things like being able to go to the toilet or get in and out of bed, those simple things that they will be able to hopefully manage on their own after rehab. And so that's the group that we typically target for inpatient rehab. People who are more mild might go to outpatient rehab, and this is what I'm talking about in our talk today, the severe strokes. So we split people up into kind of functional bands, we call them, mostly based on mobility. So this upper band, you have very minimal deficits. So probably you would do well even without any rehab. So they typically would go to outpatients in broad strokes. This middle band is who I was just talking about, those people who have deficits that they can't exactly go home right now, but you know that they will improve. And then this lower band is the people who are very severely impaired and with the lowest chance of going home or being independent. And in this table, they write the caveat of unlikely to achieve functional independence unless young, and by young they mean less than 55. So in Canada, about 62,000 people will have a new stroke, and then 6,500 of those people will receive inpatient rehab, and the median length of stay across the country is about 1 month in rehab. And then this is traumatic brain injury and how we grade severity. Similarly, it's really hard to keep track of numbers for traumatic brain injury because many people have concussions or these type of things that they might not go to hospital or may not be recorded appropriately. So I don't have great numbers in terms of a similar pie chart for traumatic brain injury. We keep better track of the moderate to severe injuries that typically would end up in hospital. And so mortality rates for severe traumatic brain injury are quite high, actually. Some numbers up to 40 or 60% after 1 year from their injury. So what I wanted to talk to you guys today about is how at the acute care site we can better kind of coach these patients who are severe to understand better what their anticipated trajectory is so that they can have a more realistic and better functional goal so that their time in rehab is better utilized. Because the rehab stay is brief, and so if their goals aren't appropriate, then a lot of our time can be spent on trying to reframe their goals or help their goals become more realistic rather than spending it on the things that we need to teach them to do. So these are some kind of typical illness trajectories that you guys are familiar with. For instance, the one on the left is if you have some kind of cancer, you're probably doing well until you have some event or incident and then a short period of significant decline and you die. Versus this middle category, you have some kind of exacerbating illness like heart failure that you go into hospital because you have some episode, and when you leave the hospital, you're not quite as good as you were before you went in, and you have a few of these exacerbations, and then you may pass away from this illness. And then the third kind of typical illness trajectory is you have some kind of dwindling illness, like they say dementia, where you aren't too great to begin with, and then it's a downward trajectory. So these are things that I think we're familiar with, and the endpoint is death for all of these things. And so it's easy. I think it's maybe relatively easier to counsel patients about what's expected because there may be more evidence and more kind of background of what you know about these illnesses. So this paper was talking about a fourth trajectory, which is after severe acute brain injury. In this paper, they classify stroke as part of brain injury. They count stroke, traumatic brain injury, and non-traumatic brain injury as being in this group. So their suggestion is that the trajectory after a severe stroke is you're doing fine, and then you go to the hospital because of your stroke or brain injury, and Either you keep doing that and you may die, or you make some kind of recovery, and then it leaves like a question mark here of what this next stage is. And so that is how they want acute care to kind of frame this acute portion of their stay. And this is another paper. This is a study based out of Scotland. And this is more for that next step of after what happens after here, specifically for people with severe. Moderate people, we anticipate they will improve, not improve quite back to how they were, and probably make some slow and steady improvements from when they leave the rehab hospital and either stay stable or some improvement. But after severe stroke, this is the anticipated trajectory. So what they did was they took all comers admitted to this hospital over 2 years with a severe stroke, so a total anterior circulation stroke. And so that was 219 people. And they took the numbers from those people, their quantitative part of their study, and then with 34 people they did a qualitative study. So they did interviews at 6 weeks, 6 months, and 1 year to get their perspective of what their illness course was like. And in those interviewed patients, they made sure they got a mix of at least 10 of different kinds of strokes, so hemorrhagic versus ischemic, over age 70, under age 70, male, female, if they had a PEG tube or not, if their stroke was on the right side or left side, if they had aphasia or not, if they had some kind of serious medical comorbidity or not, and if they were going home or not. So they had this group of people, and it's very interesting because I think this is what we see when we follow up on these people with severe stroke, that the improvement, they don't necessarily continue to improve after they leave the hospital. Actually, when we see them in follow-up, they usually tell us that I was getting therapy every day in Holy Family or wherever, and I was making improvements. Now that I've gone home, I'm only getting therapy maybe once a week or something like that, and I'm getting worse. And sometimes you'll even scan them again because they're saying that I'm getting worse since I left. And I think this reflects what we will often see when we follow up with our severe patients, that they have their illness, they leave the acute care hospital, they're a little bit better, have improved from their worst. They go to rehab, and they might have some kind of illness like a pneumonia or something that brings them back to the hospital. They get better, but they have a slow kind of trajectory of decline after their stroke. So in this study, people with severe stroke, the 1-year mortality was very high. Of everyone that came in these 219 people after stroke, 60%, very high mortality, either from this episode here or from their initial illness or at the end point. And so they have some kind of quotes of patient or caregiver perspective that I wish that people would help us in making more informed decisions, planning for the future from day one. The focus was always on active rehab, recovery, motivation, and hope, but much less discussion and preparation for this trajectory of limited improvement. And while I value maintaining my sense of dignity and personhood, they felt trapped. And while they initially wanted to be discharged home, some suggested that it would have been better if they had passed away rather than living with severe disability, or that you go home and then you realize that you didn't really want to be at home because your care needs are so high that it's very challenging and suboptimal, and later realized that it would have been better to go to a nursing home. So I think as well, this is kind of a perspective that we hear more often from the caregiver than the patient themselves, just anecdotally, of that this future planning or forward planning is very important for us. And from when people get to rehab, it can be a challenge depending on what kind of messaging they've received. If they've received this messaging that you're going to go to rehab and you're going to improve and you're going to get better, and my arm is going to work again, my leg is going to work again, and it'll be fine, that can actually be really disruptive or not productive to their rehab course, because they're just waiting for their arm and leg to get better, not learning how to work within their challenges. So that is a huge problem of when patients come to us and they don't have a SMART goal. I'm sure you guys have seen this, that we like to set SMART goals, so goals that are very specific, measurable, realistic, and obtainable, and you set a time limit on these goals. So in 1 week, I'll be able to do this, and in 2 weeks, I'll be able to do this. So setting up these goals in acute care is actually very important to set these realistic goals so that they don't get to rehab and wonder why they're not working on the goals that were set initially, if those goals were either unattainable or not realistic. And of course, the patient can have goals that are not realistic, but we have to help them to set our team goals and hopefully merge those goals or work towards those goals becoming similar. Because the length of stay, as I said, is short. So across Canada, it's maybe 31 days. In BC, this was a study done by my colleague, and in BC, the length of stay median is 42 days. So that is 6 weeks, so 6 to 8 weeks for the average stroke. For the severe stroke, maybe roughly 3 months. So they may have been already in St. Paul's for 2 or 3 months. And so when you get to rehab, the time is very limited. And so we need people to be able to work on what they need to work on, as well as have some hope and that things are going to improve. We're not there to crush people's hopes, but we also want them to have realistic goals. So one example of this is what a therapist told me, that this is a common problem, that they say, I want my hand to work again, let's say, and they have a very flaccid hand at 1 month after their stroke. And so whereas the therapist would like to work on teaching them how to use their other hand to do things and work on positioning for the weak hand, the patient just wants to work on stretching, range of motion, and kind of facilitating to get that flicker to be maybe a bigger flicker. And so there's only maybe 1 hour of OT a day, and you kind of have to choose what you're going to work on. So I thought this was kind of a good illustration of what we see, that in rehab, let's see if this will work. Maybe not. But this is just a video of someone learning how to tie their shoelaces with one hand only. So there's a one-handed technique for tying shoelaces. So if you can't do both hands, then you learn how to do it with one hand. And that might be the kind of preferred goal or optimal goal after their stroke. But if they can't do that, then maybe next in line, the therapist might say, let's get elastic shoelaces that you can slip your foot in and you don't have to tie it up. But maybe if they can't do that even, they might need adaptive footwear to make it even easier, that they get new shoes to be able to fit in. And then only if they can't do that, then they need someone to help them put their shoes on. So that is often what the process of rehab is like. You're not going to get to rehab and there's some magic there and we can just make your hand work again. It's more of learning partially, especially with severe disability, learning how to not waiting for this neurologic improvement, but working on your functional improvements and learning how to adapt to your new impairments and best to make it most efficient and make that the best use of your time. So that's kind of the process that we try to go through. But if the patient is like, I don't want to work on this, I'm just waiting for my hand to get back to normal, that is a huge roadblock, and we can't go down this path until they agree to work on these things. Yeah, and that similarly kind of happens in all fields of whatever their impairment is affecting, that if they don't want to go down this path with us, it's challenging to do this rehab process. So we have some good evidence-based resources that we usually suggest people to look towards, and there's evidence for both acute care management, pre-hospital management, and rehab management. So the Canadian Stroke Best Practices guidelines are often what we refer to and are ideal to work towards. There is the what we call EBRSR, but evidence-based rehab reviews. These are reviewed every 2 years of rehab evidence. This is also Canadian, and they review evidence from everywhere, but this is a Canadian group that does this, and this group similarly does the evidence-based research for acquired brain injury. So all these things are super easy to just look up online. You don't have to log in anywhere, and if you have a question about some kind of acute care issue, management of stroke or brain injury, or anywhere along that pathway, there's probably evidence for it, and so you could look up on one of these resources. The next kind of question is, so I told you that probably we look at some prognostic indicators to help for us to determine if people are going to improve and do really well or not improve and continue to do poorly, and that helps to factor into how we select the best candidates for rehab, given that it's a limited resource. So it's actually very obvious who will do well and who will not do well. Those top two things, their age and severity of the stroke or brain injury, have time and time again in many papers been shown to be most informative for how people are going to do. And so there are obviously other important variables, like if they have some family member or caregiver that can help them in their process, or how poorly they were functioning or good they were functioning before, has some relation. So if they weren't even walking outside 2 blocks before their stroke, they're not going to do that now. So I wanted to talk to you about age, young age, and severity. So age is obvious. For stroke, it's usually older people that have stroke anyway, so the young versus old age is somewhere around maybe 70, 75 of what we consider a younger stroke versus an older stroke. Age for if you have a brain injury is 40. So if you are over 40, the prognosis for brain injury is typically poor. And how we measure severity, this is a common scale that we use, our FIM score. And in the hospital, you guys probably do the alpha FIM, which is slightly less onerous, that you only, I think it's 5 and 2 measures, and that number is extrapolated to give you a FIM score. And these are the items, 18 items. The left ones are their motor function, and right one we consider part of their cognition. Everything is rated out of 7. So if you're really good, then you have a really high number, 126. If you're doing really poorly, your number would be 18. So higher numbers are better in this case. And so this is a really complicated kind of flow chart of what we call functional rehab groups, or kind of broad strokes of who will do better and who will do less good. So you'll see it's based on their motor FIM, or the subset out of 13. So out of the 13 items over here. So your maximum score is 91, and so people who score on the low end, so about half, are in this pathway up here, where if you are very weak and you are young, then you'll probably do well, but this is considering that you're starting really low, so you'll probably make some improvement from that very low point. Not that they'll be back to normal or something like that. Versus if you have a low FIM, low motor FIM, so low function, but you're older than 74, and your cognition is good or not good, both have less recovery potential or lower. So if you're old and very weak, even if you're very bright and very smart, limited recovery potential. And then these groups from 4 to 7 probably do the best in an inpatient rehab setting. So either you are kind of reasonably strong. If you are really strong, so this lower group, and your cognition is not good, it's probably still okay. So you're strong enough that even if your cognition isn't great, but you're very mildly weak, you'll probably do okay. If you are so that is kind of what we think about in our, if you're mildly weak and your cognition is bad, you'll probably do okay. If you're really weak and you're old, even if you're really bright, you're really with it, less recovery potential. And then this bottom group is your really strong and you're doing well cognitively. Ceiling effects, so we don't actually see number gains in terms of the FIM because you're already at the high end of the FIM. So this is what we think about, and the usual admission score, total score, 74 out of 126. Usually we categorize severe strokes as less than 40. So even in the interquartile range, typically rehab is geared towards these middle range people. And the gain that you'll get is 20 points. So you're not going to go from here to there. It's very unusual, very rare. You need to coach someone that you're going to make a modest improvement from where you are. And so, this is kind of the thinking that we use in terms of who we take into rehab if they have a severe stroke. And this is another kind of interesting study that's very relevant to what you guys do, the NIHSS score stroke severity scale that every stroke patient will have kind of in emergency on admission. So in this case, lower scores are better. So if you have 0, you're great. If you have a high score, 42 or 21 or above, you're bad, or have a lot of impairment. So everyone that has a stroke has this. And what they did is this is a branch off of the data from the ESCAPE trial. So the ESCAPE trial based out of Calgary, but multi-center, which was for TPA alone, if they're appropriate for that, or TPA plus endovascular treatment. And so they had 316 people, about half of them received the endovascular treatment. And the outcome was that modified Rankin scale. That was their primary outcome, which I talked about, the minimal disability, severe disability, grades in between that. So from that data, they split people up into 3 groups. So people who did very well, large improvements, minimal improvements, or no improvement. This is from their treatment. So either they received just TPA or TPA plus endovascular treatment. So I cut out in their table what things seem to be significant. So it seemed to be that more people had received the endovascular treatment in those that improved versus those that didn't improve. So it showed that it was helpful to do the endovascular treatment. people who improved well, most of them survived 90 days versus people who didn't do well, 43% of them didn't survive 90 days. And this is interesting. Their NIHSS score was lower for people who did well, so 13, versus 17 for people who didn't do well. So more severe strokes, even at presentation at emergency, don't necessarily do well even if they receive the endovascular treatment. And so the data that they found from this was taking that data and extrapolating it to who could we have predicted would have done, or how can we use this to estimate their prognosis to take it as a surrogate earlier on for their 90-day prognosis. So they found in this paper that people who do well will declare themselves by 2 days after their stroke. So if this blue group is the people who did well, by 2 days, if they're almost back to normal, those people will continue to do well and have good improvements. Those people who don't respond, these green people, they'll continue to do poorly at 90 days. So this is at 2 days, this is at 5 days, and this is at 30 days, trying to use these as markers for what their 90 days is going to be like. You know by 2 days if you've responded well and that you will continue to do well. And this is specifically for people who received ischemic stroke, who received endovascular treatment. But similarly for TBI or traumatic brain injury, these are some of the factors that we look at. That age and severity are one of the most kind of predictive of how they'll do. And this usually translates into better FIM score, better discharge destination. We don't have great measures yet for the common thing that's happening or these hypoxic ischemic injuries. There's this one study that looked at a scale measuring these things, and they found that it was quite reliable or predictive at who would do well or improve and not have modified Rankin of death or severe disability, looking at their initial GCS, return of spontaneous circulation, and their CT scan, what it looked like. And not going to talk too much about this, but if you have had a TBI, there's some evidence that down the road on a delayed fashion, you have increased risk of things like dementia and movement disorder or Parkinson's or some kind of neurodegenerative condition. Okay, yeah, and so those are the main things that I wanted to talk about today. Yeah, open to questions. Yes.
Thanks, Grace. That was great. I was interested, when you mentioned that, say, OT, occupational therapy, for instance, at GF Strong or whatnot, they would max out at an hour. I'm just curious, just for us non-rehab folks, like St. Paul's or acute care, GF Strong, and maybe if you could contrast like private rehab facility, like people with more means could go to. What's the difference in physio, OT, and speech that like we could conceivably see between the units, and do they sometimes converge like on those?
Yeah, so in terms of intensive rehab, theoretically they're supposed to be very comparable across all intensive rehab centers, so you should be receiving 45 minutes to an hour of physio, OT, speech therapy if you need it, and then there's often supplemental things like music therapy groups, balance group, different things like that. So presumably they are similar across intensive rehab centers, and but that's the ideal, and there have been many studies they had students following these patients around and seeing what the active rehab time was in centers like GF Strong, and whereas you're supposed to be getting maybe 3 or 4 hours of therapy a day, I think that study showed there were actually only 45 minutes of true active therapy time. Time is spent from the therapist doing charting, looking for the patient, doing all these different things. So yeah, it's a shame that the true active rehab time, even in the most intense of places, is very limited. So it may be that private rehab places may be better. Often people will supplement with their own private therapists that come in. And then in acute care, dependent on if they are able to mobilize, the caveat is there was a trial showing very early rehab within 1 day after their stroke is not good. So don't mobilize people in the first 24 hours necessarily, but kind of dependent on therapy resources and time. And I would let the therapist speak at what the average time they feel they have with their patients on the acute care ward. Yeah, and then the other centers, not intensive, are less than that.
Any other comments or questions? Maybe I could follow that up. If you were going to design the ideal rehab facility, how much time would somebody be doing physical therapy, occupational? What would be the optimum?
Yeah, so whatever they can tolerate, and it has been shown that most of our costs of intensive rehab or inpatient rehab are actually used on nursing, whereas the therapy cost is actually very small and a very small portion of their time. So if they can tolerate 2 hours a day, that would be great, of 2 hours of physiotherapy a day. But often, depending on their age or fatigue related to stroke, they often can't tolerate that. And there have been studies about doing 7 days a week of rehab versus 5 days a week, and it hasn't been shown that it's necessarily better to just plug on and go through every day. We need some rest. So there's some evidence that 5 days is a reasonable amount of time.
So I guess to follow, so if any of us train, if you have the ability to train all day, we wouldn't train for 8 hours. So is there an optimum time, or is it all individual?
I would think it's very individual, depending on ability to tolerate and kind of mixed with other things, other needs that they have during the day. I don't know, Evan.
To add something, that's important from the provider's point of view, that we can't underestimate the power of the rehab nursing care. And this is the care that is in between all the therapy sessions that will be found in rehab in terms of facilitating their independence. So the bedside care model that the therapists and the team develop are facilitated by the nurses in terms of their morning care routine, their transfers, all the things that they're trying to teach at the same time. So the rehab nursing part still is part of the functional recovery model of care, that without them, the intensive part of the one-on-one time will not be translatable from a meaningful way for the patient's day-to-day improvements. So the model, not just the therapist's time, but can you impart that functional view from the doctor's point of view of the nursing care to facilitate that. So you do see a lot of difference from the RN and LPN's agility because of the time and the resources and the training that we have in between the group classes and the one-on-one time.
So to follow that up, if we, from an acute care center, if we also have the ideal model, what would be the ideal model to transfer to a rehab facility?
Yeah, so we'll be thinking about that for the next 6 months in terms of some engagement from Providence in general. We want to see how we can improve the whole rehab journey. That it looks very similar, but it's not rehab being a destination, but more of a philosophy of care. So from day one, can you facilitate continence? Can you facilitate your skin issues or contractures or communication? Because we've had many that, unfortunately, hear from them and also the qualitative literature, that they really are waiting for some, not rehab, but basically participation after the medical issues are sorted out. So this is one of the things that we're going to be trying to lead in terms of how can we at Providence be that place where you can be not just for your medical needs, but a real change in the functional view of care, such that despite your limited resources of time and nursing and model care, can we do that in a similar fashion that we can have the luxury of doing in a rehab facility. So rehab more as a journey rather than a destination of the ideal.
Well, I'd like to thank the physiatry group and Dr. Lee especially for the training. Thank you.
Thank you. Are you going to the rehab?
Yeah, I've got a client over here. Throw it on.
I think it was closed.
I'll try.
So research is and how often that is used. Because often, I mean, the onus is on the rehab to show that we have readiness, but we don't have time to do it now because we're not a rehab center. We have a lot of patients. We don't have time to, in our care, patients to show that they can tolerate an hour of therapy. So how often or when, in what circumstances, would you expect somebody before we can do enough rehab with them that will take their first? Yeah.
I think in like practicality, I don't think anyone has ever come back to St. Paul's, but I know, unless they have some medical issue or something like that, right? So I think in practicality, it's very rarely enforced in Vancouver. And so I totally agree. Like, it's funny because before you see the patient, usually the rehab team is like working to try to prove that the person is appropriate. And then after we say, okay, they're appropriate, like there's no rehab anymore. And so, yes, exactly, they wait, and then there's a huge gap. So I personally don't necessarily feel that, like, if we know and when we see them, we know that they'd be, like, good and good candidates, we wouldn't be like, oh, can you prove that they can tolerate 1 hour of speech therapy? We wouldn't necessarily say that, but if we have concerns, and it seems like that would be a concern, then we would say that. But if it's clear that they would tolerate, I don't think we would ever be like, oh, but show it to us.
Yeah.
You know what I mean?
I actually feel, I mean, for speech, it's maybe not as big of an issue as it is for OT and PT, actually.
It's not as big of an issue.
Yeah,
they
you're not.
themselves once they're a whole family.
Yeah.
In general, we kind
But,
of see they're going to be just accommodated family education.
But more of like in our time that we spend with those patients, which might be like 15 minutes or 20 minutes, like if they're falling asleep during that time, then we'd probably ask for you to prove that they can actually participate in a 30-minute session or whatever. But if they seem fine, we wouldn't say, yeah.
Yeah, it's more of a global holistic thing to say. And plus, whatever they do in the nursing side of things, I had a patient in the AA just finally started bedside care plan with nursing ability, so we can see how straightforward. Otherwise, it's hard to tell. I don't know if there's anything that you would change to help that.
Yeah, I don't know. I mean, I just see sometimes our stroke people have to get put down on those priority lists because we're going to discharge issues, and then we can't get to them to even give you good notes or taking it out of you. So
I think, if there's no notes, that is a problem.
there will be something.
Yeah.
But, sometimes, you know, it's
a
hard
whole
to get
picture,
to them.
right?
Yeah.
Child day rehab program anywhere in the province?
What do you mean?
Like, where the patients are picked up. Like, it's kind of like a READY program, but within the hospital setting, within a rehab hospital setting. So they get OTPT speech all together, but the patient is at home, sleeps at home, comes in the morning, spends 3 hours, has lunch there.
Oh,
It's like IROC.
A day
And it sounds like our
IRDP,
yeah.
Yeah.
5, 7, 8 years ago.
Yeah.
Vancouver, Richmond.
Yeah.
Because of other issues.
It still exists
I
in
think,
Give Strong.
Yeah, IRD still exists.
You guys have it.
Give Strong, yeah.
IROP at Lionsgate.
Yeah.
The question is, how do you do that model? Where do you take things? I love those ideas. I think we need to see them a bit more creative. Calgary was able to bump up their percentage of rehab because of that.
Yeah.
But Providence is actually doing very well. When I see the regional rehab report card, the fact that we need to get over 15% of stroke patients getting rehab, like, to like under 15 at other places. So I know from the point of view, when someone's a candidate, you want to go for it, right? And it's hard to see when someone, well, you see someone you want to root for it, but you have like a pretty good number. And I thought it was going to fall last year, but once they started to kick on the regional lead, I'm like, okay.
That's nice to hear that, though, right? That's awesome to hear that.
That's why I thought it was kind of like, that's true, that's Calgary numbers.
Yeah.
You know, when usually it's, 10.
Exactly. Kind of fits with the global number. Yeah.
Maybe it's more subacute stroke, and it's not like those ones that die so readily in PGH and things, but you're able to have a bit more moderate here, and something a bit different here.
And I still think, somehow we need to feed back to you guys, like, who did well and who didn't do well.
That's really good.
Yeah.
And also, at what point do you consider them severe? Like, I know it was TPA at 2 days, but because then our
From day one.
Because our
Day one.
doctor's telling them things,
Yeah.
right? Well, I mean, you can see,
Yeah.
size and carbs or denseness,
Yeah.
but then some people,
I agree.
I don't know.
So I got clients on
Yeah. I totally agree.
Thanks, Grace. I'll see you tonight.
Yep. That I think the messaging, I don't think it's coming from you guys, but it's coming from the